So I hope I can use it correctly. All right. So this is a disclaimer, always been employed by Dubai Academic Health Corporation. Now we're going over the holy month of Ramadan. Again, one of the issues that, again, the prevalence of diabetes is increasing. The number of diabetic are increasing. And we have to get kind of comfortable how we're going to treat our diabetic patient in the holy month of Ramadan. One of the things we remember that not only that the majority, at least 80% will fast in Ramadan of those who are diabetic, a lot of patients, even if we advise them, if we consider them high risk or very high risk, actually they tend to insist that they would want to fast in Ramadan as much as can. So even, if you have a patient who's high risk, you really need to try to see what you can do to mainly minimize risk of hypoglycemia anyway, which is the way we're going to look at treating our diabetic. And again, when you're looking at the fasting, a few things we have to remember that, again, you have the patient fasting for so long time. And then this is usually followed by such a big, large meal. And that, of course, will increase the risk of sudden increase in the glucose. On top of it, of course, in fasting, if there is no adjustment in the treatment, especially if they're taking agents that can cause hypoglycemia like insulin, of course, that will increase risk of hypoglycemia. We have many trials that showed very clearly that usually you have 3 to 4 times increased risk of hyper and hypo during Ramadan. And one of the, when you look at it and you look at different, drug or class of drugs, it comes to mind, why not using GLP-1? Because it's a drug that's, an effective anti-diabetic. It has cardiovascular benefit. But on top of this, it may actually help patients that when they fast, once they break the fast, they don't really overeat. And this is one of the big issue we run with it is typically if you try to ask your patient with Ramadan, the majority, if you look at their glucose post iftar is going to be quite elevated. Now, when you look at GLP-1, again, you have to remember that they're not all equal. It's, when you say GLP-1, again, we put it as a class, but they're not exactly similar. So again, you have what you call exendin-based therapy, and those are not exactly similar to the human GLP-1. And of course, we have the lexizanatide, and then we have the exenatide that started, of course, that was the first GLP-1 as Byetta, and then we have the weekly. Now, one thing with them, they did not show, at least in their cardiovascular data, that they have any cardiovascular benefit. Now, of course, there's issue with the trials you can talk about, but at the end of the day, they did not show CV benefit, number one. And of course, being not exactly similar to the human GLP-1, they have a higher chance of mainly making antibodies. So, in their trials, you're going to have a good percentage of patients that have antibody titers against the product, and actually some of them have very high antibodies that could be, in theory, the responsible for the fact patient may stop responding to the treatment. So patient will be, for an example, on weekly exenatide, and then after a year or so, they have high antibodies that don't respond to it. The second one is, again, the human GLP-1 based therapy, and again, here we have dulaglutide, liraglutide, semaglutide, and the oral. Now, we can see here the weight as kilodalton. So, for example, dulaglutide is a big molecule. And, one of the things when you have a big molecule, it doesn't cross the brain barrier. And I think this is part of it why you may not have as much weight loss with it. And again, with semaglutide, we have the oral, which is, the only oral GLP-1 we have. So, do we have any data on Ramadan? And the answer is yes. So, the first trial is Lira Ramadan. I was in part of it. And again, mainly it's a trial trying to see the safety and efficacy of using liraglutide in patients with type 2 diabetes. And the baseline therapy was metformin. So it's hard to recruit because, again, you want patients to be taking metformin SU mainly maximum. And so mainly here to compare what will happen if I have a patient taking metformin SU and what will happen if I have patient taking metformin and liraglutide. And again, what you see here very clearly that when you look at the change in fructosamine, again, they're using it because it's short period during Ramadan, there was somewhat similar reduction in the level. So that's number one. And then the second issue is what's about the other parameter of efficacy? What's about fasting glucose? So again here, if you look at liraglutide, so this is kind of dark blue. Now again, it doesn't show very well on the slide maybe. And you compare to sulfonylurea, you can see that you were able to achieve a better fasting glucose with liraglutide across the board. And you can see here down between visit 8 and visit 12, it was the holy month of Ramadan. So there was multiple visits and 4 visits and so on. Now, the second thing is the change in the A1C. Now, both treatment arms reduced the A1C, and you're going to say, well, why the group, who did not switch to liraglutide dropped the A1C? And the answer is very simple. They had so many visits. There's no way you don't control patient better because they had been contacted over and over and over. And patients tend to do better when they are followed so closely. Typically, you're talking here during the oldest visit, usually patient may see the endocrinologist or the PHC 2 times, and here you're talking about multiple visits. So that, of course, was a factor in reduction, but despite that, if you look at liraglutide, you can see that actually over time from the baseline, there was a better reduction in the A1C in the liraglutide versus sulfonylurea. Now, what's about the safety part? So first, you look at the weight, and then you look at the hypos. And here again, it is expected. It's not unexpected that the patient will lose weight with liraglutide. And it's not unexpected that usually you don't have weight loss with sulfonylurea. But at the end of the day, you can see even here the weight kind of drifted. And I think part of it is because patients were followed very closely. And so at the end of the trial, there was maybe 0.54 kilogram weight loss versus almost 4 kilogram. Now, it comes to the fact of the hypoglycemia, and I'll spend a little bit of time on this. So, confirmed hypoglycemia, so mainly this is a patient who had hypos and, confirmed by glucometer reading. And again, there was a reduction. What's about the ADA criteria, which is below 70? And again, there was a reduction. Severe, there was no severe hypoglycemia. And then documented, where patient documented that they had symptom of hypo, but there was no documentation, i.e. as a blood glucose check, and also was significantly reduced. And then those who had low glucose on the machine, but they did not have symptoms. And across board, what you can see that actually the symptoms of low sugar is reduced, which is, again, expected if you're going to compare GLP-1 versus SU. At the end, you have to remember GLP-1 will stimulate insulin secretion in a glucose-dependent manner, so that kind of protects you from hypo. But not only that, the suppression of glucagon is glucose-dependent matter. So when the glucose goes down, you still have unintact glucagon secretion to counteract and reduce the chance of having loss. Now, the second or the last part is the nocturnal. So nocturnal in definition of the trial is between midnight and 6 in the morning. And there was a reduction. Actually, there was no loss in liraglutide. Now, here the number looks pretty high, but you have to remember this is mainly adjusted because this is calculating the hypos during Ramadan, and you have to multiply by 12 times to count for the whole year. And, that's why it looks pretty high as 156, event per 100 patient years. So, per 1,000, patient years. So at the end of the day, if you are going to treat, and you're going to count that if I'm expanding, 1 month duration by 12, you are going to get what equal to 156 events. Now, what's about SEMA? So semaglutide, again, it's a GLP-1 available initially as injectable and now available as oral. It's, again, the only oral GLP-1 treated that's available. Of course, we have cardiovascular data that showed significant safety parameter. We have CV efficacy data that's ongoing. And on top of that, you have the cardiovascular data on the injectable semaglutide. And at the end, for semaglutide is 94% homologous. So again, this is what's different than Exendin, which typically about 65%. So you have really low chance of getting any antibodies. And typically, like most of the products, they had a spacer and side chain fatty acid. And then, this is how you develop the product. Of course, you do the modulation in the amino acid to decrease the chance of get degradation by DPP-4 inhibitors. Now, to be able to absorb through the stomach, they add the snack. I cannot pronounce the whole thing, so we always say snack. Now they even add changes in the snack to improve. And so mainly what it does is going to increase locally the pH in the area where the pill, and that's going to have significant effect to improve the absorption of the product. So you have a degree of absorption of the product that's predictable over and over, because you don't want to have a mechanism that may allow 1% of the product to be absorbed today and tomorrow is 0.2%. So it allows stable, expectable absorption of the product. Now, at the end of the day, you to look at the efficacy data. So, does it work if I give it orally? And the answer is you have all this data. And typically, Novo will do always a lot of trials. They will look at all different combinations. What will happen if a patient takes mono? What will happen if they take metformin? What will happen if they take SGLT2? So if you have any question, you'll have a study that kind of fit the criteria. So the first one is Pioneer 1 as monotherapy. And again, you look at the reduction in the A1C. And again, with the SEMA 14, you have a reduction of 1.4. But you always have to look at it in a perspective of the baseline A1C. So here, in this study, baseline A1C is 8, and you drop 1.4%. So you have to put that on perspective. Of course, the higher the A1C, the more reduction you're going to get. Now, what's about IMPA? And here you have to remember, this is comparing to IMPA 25, the high dose. And again, 1.3% reduction versus 0.9 with a baseline A1C of 8.1. What's about sitagliptin? So again, here, there was a reduction of 1.1 versus 0.7% with a baseline A1C of 8.3. And then even if you compare it to loriglitide, the injectable daily GLP-1, also there was significant reduction. There was a renal study, of course, flex study to do flex titration. And there's even a study compared to add it with insulin. Now, the diet thing when you add it to insulin, you have to remember here, baseline A1C 8.2, this is patient who well titrated. You have to remember this is an interventional trial. So patients are not real-world evidence. So they had a research coordinator, they had a titration schedule that enforced, and despite that, adding the oral SEMA will have a further reduction of 1.2. You have to remember, those patients in the old days, the only treatment we had is to go to 4 shots a day. Now, what's about the change in the body weight? You actually also see reduction in body weight, and again, the reduction in the weight is dose dependent, and we know that with GLP-1. So, you give a dose, you go higher dose, you go more reduction in the weight. Now, of course, there is a limit at which you have the glucose reduction, but then if you go beyond this dose, you can see even further weight reduction, but not necessarily more glucose reduction. And again, what you see here, that you're averaging about 4 kilogram plus minus weight loss, again, with a baseline weight of 91 kilogram. And that's, again, across all the trials and across even the Pioneer 8 when you add it to insulin. Now, adverse event, again, we look at the hypoglycemia, and again, you can see that actually the drug doesn't increase risk of hypoglycemia. When do you see it? Well, if a patient having sulfonylurea in the background, or a patient have insulin, of course, and that's something expected. But again, look at, for example, the Pioneer 8. So Pioneer 8, again, you add in the product to an insulin, but typically, if you have a patient on insulin and you lower the A1C by 1% or 1.2%, you should have usually double or even triple risk of hypoglycemia. But what you're seeing here, reduction in A1C of 1.2, no increased risk of hypoglycemia versus placebo, and the weight loss. So that's the way you look at it. So if you have a patient uncontrolled on basal and you titrate them fairly well, and their fasting is somewhat controlled and their uncontrolled is really the post-meal, because if you have an A1C of 8.2, and your fasting is controlled, it's post-meal. Consider using this rather than going to meal insulin, of course, which will have even much higher risk of hypos. So it is convenient. The other good part of it, again, you don't need to do any adjustment for the renal problem. You don't have to do adjustment for liver problem. And if somebody is older or not, you don't need to do any necessary dose adjustment. So it's once daily what you take it. Now, of course, there's a precautions. There's a way to take it. Again, you have to remember, is usually you take it in the morning. You wake up, you take it with a little bit of water, less than 110 ml. Typically, I tell the patient, Novo provided this beautiful kit with a clock that I found it hard to use, so I stopped giving it to a patient. And then you have this small, glass cup that you should use. Actually, I tell patient drink it with a little bit of water just to swallow the pill. Make life easy. You should not drink too much water with it. And then wait 30 minutes. Don't eat, don't drink, and don't take any other medication with it. And that's to the extent of it. How do you start? You start with 3 milligram. You do it for a month. No issue with it. You go to 7 milligram. And then you see how the patient is doing. If they do very well, that's good. If their sugar is still uncontrolled, you consider increasing the dose to the 14 milligram. Now, I'm going to go over a case here, and I'm going to show, and again, this is just illustration This is an actual patient I have out of many. And this patient actually was in the OSIMA trials that's going to be discussed later. So I have this patient, FD, who's 65 years old, 16 years of diabetes, BMI of 35, A1C of 7.6. It's not terribly high, but it's abnormal. She has a history of hypertension, hyperlipidemia. She is on medication including valsartan, 80 milligram a day, rosuvastatin, 20 milligram, ezetimibe, 10 milligram, vildagliptin, metformin, 50 on 1,000, and IMPA, 10 milligram. She, like the majority of us and the patient, we have sedentary life. And of course, the concern always try to see, can we control the glucose? Can we help her with the weight? Now, we went with the patient over the possibility of the options. A patient, like a lot of patients I have, they tend to be very hesitant to do any kind of injectable therapy. So they prefer to go oral therapy. So what we did with this patient is we stopped the vildagliptin, metformin combo, and the empagliflozin, and we went to give the empagliflozin metformin 12.5 on 1,000. Now, of course, by doing that, I increased the EMPA dose from 10 to 25, but again, this usually causes an additional 0.2% reduction in the A1C, so that's one thing to put in fact. Then we start the EMPA 3 milligram. After a month, we went to 7 milligram. The patient did tolerate it very well. Now, the question is, do I increase the dose or not? And to really show you is what I did is, I did not increase the dose further. The reason is she continued to respond very well. She lost quite a bit of weight. Again, she went from 91 to 76. Now, this is kind of plus minus 14 kilogram, which is equal to about 16%. Now, does it mean every patient will lose a 16%? No, of course. But this is actually super responder. The problem with GLP-1 is sometimes you really don't know the response. And you cannot predict the response due to the duration of diabetes. And you remember this patient had diabetes for 16 years. You would assume she would not respond. But this is actually a clear example that actually patient would respond well even if they have diabetes for 16 or 20 years. You would, lose a chance to give them this result, which I'll show you, by giving them, for example, insulin. Not because insulin is bad, but why don't we try this at least? And what happened with her is her A1C dropped to 5.5%. So what I did is actually, I'll show you here. And so this is the graph with her, and she was again in the OSIMA trials. And you can see here down is when we started the SEMA. This is from the electronic health record system. And I started with 3 milligram for 1 month, which you see the small purple kind of column. And then we went to the 7 milligram, and I did not need to increase the dose. But what you can see here is this beautiful drastic reduction. And this, you would have missed it if you just said, you know what, you're uncontrolled, you're taking 3 oral, let's go to insulin. And so one thing you need to remember, that diabetes is a disease, it is progressive, but when you come to GLP-1, you have to remember it is an effective treatment. I showed you on the slide that when you compare it to other agents, it is superior to liraglutide. Here we're talking about the oral SEMA. It's even beneficial when you add it to insulin. It's superior to IMPA 25. It's superior to sitagliptin. So you have to really consider it. If a patient have an A1C, let's say for example, if a patient have a baseline A1C of 8.1, 8.2, and they're taking metformin, for example, would you add DPP-4? Maybe not, because DPP-4 with baseline A1C of 8.2 will give you about 35% chance to be below 7%. Assuming your target 7%, not 6.5. So see where the patients, see where their baseline A1C, and then you decide on the treatment. So it is an effective treatment. Having an oral formulation will make life easy. I think one of the problems a lot of patients have, especially in the population I see, is being injectable GLP-1. I always have a lot of hesitation. So when I moved to here from the state, I have a lot of patients taking injectable GLP-1. But the problem here, there was a lot of hesitation. And I think having an oral formulation will make things more acceptable. And it will simplify the treatment. And not only that, you can be more aggressive earlier. You don't have to wait to be, the 4th class of drug you use. You can be the 2nd in line or the 1st in line even. And again, it is an effective treatment. You have to consider it. It is very safe. There is no increased risk of hypoglycemia. And I think later there'll be discussion about the data on using oral semaglutide during the holy month of Ramadan. And I'll stop at this point. Thank you.